Simon Smale. I'm a gastroenterologist based in York. Welcome to More Than Just Medicine. I thought I would today talk about proton pump inhibitors. I often get asked about proton pump inhibitors, particularly in respect of their long-term side effects. So I thought it would be useful for me to give an overview of acid secretion within the stomach, of exactly what proton pump inhibitors do, which in short is to inhibit the acid secretion in the stomach, a bit about the indications for them and what they're used in, but also then to move on to some of the short-term and some of the long-term side effects, and then if we have time on the video, perhaps talk a bit about stopping them. So to start with, acid secretion in the stomach is controlled through a number of mechanisms. By nerves, namely the vagus nerve, which manifests its action through a neurotransmitter in the stomach called acetylcholine predominantly, through local hormones within the foregut, secreted by the cells within the foregut, particularly gastrin, which is a hormone that stimulates gastric acid secretion, and lastly by another transmitter, or local protein called histamine, which is common in lots of parts of the body. Now, all of those three things, acetylcholine, gastrin and histamine, have effects on a cell called the parietal cell, of which there are millions, if not billions, within the stomach. And the parietal cell secretes acid. Now, it does that through a thing called the hydrogen potassium ATPase, otherwise known as the proton pump inhibitor. Now, essentially what that is a protein which acts as a pump to pump hydrogen whilst exchanging it for potassium. So it pumps hydrogen from inside the parietal cell, hydrogen ion, so acid, from inside the parietal cell out into the gastric lumen, so into the body of the stomach where the food and your gastric secretions go. And it can do that at an amazing concentration, so it can make acid that's really very acid. And that's good because it helps digest your food and therefore helps absorption, and it also kills the bugs which sometimes we all eat. Essentially, proton pump inhibitors work by binding to that pump and preventing it from working. And there are a range of proton pump inhibitors: pantoprazole, omeprazole, rabeprazole, lansoprazole, esomeprazole, and they all work in the same way, although they have very slight differences in their chemical structure. They all work by binding to that pump and stopping it from producing acid. Now, in the 1980s, when proton pump inhibitors came out, PPIs, they revolutionised the treatment of many acid-related conditions, which previously had been difficult to treat. And essentially, whereas H2 receptor antagonists work for about 6 out of 10 people with severe reflux, for example, proton pump inhibitors worked for 80 or 90% of people with reflux. In terms of their indications, proton pump inhibitors can be used to treat peptic ulcer disease, and in that respect, they're often used for H. pylori eradication. H. pylori is a bug which is associated with peptic ulcer disease in many cases, and we know that getting rid of it not only gets rid of the peptic ulcer, but also reduces your risk of gastric cancer going into the future. There are reasons to not eradicate it too, though, if you just discover it incidentally. Now, proton pump inhibitors are also used for people at risk of ulcers due to other drugs, particularly non-steroidals, things like naproxen and brufen, although they're not a guarantee that you won't get an ulcer when you take those drugs. Zollinger-Ellison syndrome is a rare condition where people get a tumour that secretes gastrin. It's often very difficult to diagnose, and the priority for those people is to remove the tumour. But whilst plans are made to do that and assessments, it's important that people have acid suppression. Now, the commonest indication for proton pump inhibitors, not just in the UK and the US but worldwide, is a thing called gastroesophageal reflux disease and its complications. Now, they include strictures and, of course, Barrett's esophagus, which lots of people may have heard of and may indeed have. Now, they're used often in the long term for gastroesophageal reflux disease, and that's because in 8 out of 10 people with reflux who stop them, their symptoms come back. So in that regard, they're actually very useful in controlling symptoms. But they should be used in combination with other lifestyle changes as well, as I've previously described in other videos. So moving on to some of the side effects. In the short term, the commonest side effects of proton pump inhibitors are indeed gastrointestinal. They can cause diarrhea, and often they cause bloating. I say often, perhaps in 1 or 2% of people. Very rarely, they may cause other effects. They may cause hepatitis, they may cause problems with the bone marrow and other metabolic effects. But those things are really, really rare. In the short term, so those are the short-term things. In the long term, when proton pump inhibitors came out, there were concerns about the implications of long-term acid suppression or hypochlorhydria, which is long-term lack of hydrochloric acid in the stomach. There are also concerns about hypergastrinemia. As I've already described, the secretion of acid is stimulated by this hormone called gastrin. So you get acid in the stomach usually, and that actually inhibits the secretion of gastrin. If you don't get acid in the stomach, then then gastrin secretion isn't switched off, and you get higher and higher levels of gastrin, and they're common in people on proton pump inhibitors. The concerns regarding that have not actually, in humans, led to the feared consequences that people originally feared. However, there are some effects of having a low acid in the stomach. It may predispose to infection, and I'll talk a bit more about that in a minute, and some malabsorption of certain things. In terms of infection, there is an increased risk of infectious diarrhea in the long term, probably significantly increased, and there's evidence, for example, with C. difficile-related diarrhea, often seen in people on antibiotics, of increased rates on proton pump inhibitors, perhaps increasing the rates by 20 or 30%, although that's different depending on which study you read. There were some reports of increased rates of pneumonia within the literature, but it now appears clear that rates of hospital admission with pneumonia probably aren't higher in people with proton pump inhibitor use. Now, the reason why infection, particularly diarrhea, is thought to be commoner is because gastric acid, as I mentioned at the start, has the function of killing many of the bugs which we eat all the time, which might or might not cause diarrhea. Some of them obviously do. And if you don't have gastric acid, you don't kill the bugs, and they get to your small bowel and your colon, where they can cause mischief. So the other concern, or one of the other concerns, is malabsorption. And we know that, for example, iron is better absorbed from an acidic environment, and so switching off the acid may interfere with iron absorption, theoretically at least. Similarly, B12 is absorbed via a special mechanism, which is through a thing called intrinsic factor, and if you inhibit acid, it may not work quite so well, and so there are concerns about B12 absorption. For that reason, there are suggestions that certainly one should consider periodically checking iron levels and B12 levels in people on long-term proton pump inhibitors. By long-term, that would be perhaps 6 or 12 months or longer, as people with reflux often are. Now, the other concern is with magnesium and calcium absorption, which are also impacted by having low acid in the stomach. And the suggestion is that before people go on to long-term PPIs, they should have a magnesium check. Now, I know from my own experience that that doesn't always happen in clinic and is often difficult. But certainly, consideration to perhaps annual magnesium checks is very reasonable. Similarly, calcium should be checked periodically, probably. Now, in respect of magnesium and calcium, they're obviously involved in bone metabolism, and there is an increased rate of developing hip fracture related to osteoporosis in people on proton pump inhibitors. If one takes a large population of perhaps tens or hundreds of thousands, and you might expect 100 fractures in that population, usually who have other risk factors as well, then you might get perhaps 125 fractures in the people of a similar population who were on proton pump inhibitors. There have been consideration given, and there's been debate in the medical literature about whether scanning people who are on proton pump inhibitors for osteoporosis should be undertaken. And the current guidance is that just being on a proton pump inhibitor isn't an indication for scanning in respect of osteoporosis. However, it's true that almost all the people that get osteoporosis-related hip fractures who take a proton pump inhibitor have other risk factors. So, for example, a significant risk factor is being a smoker and being inactive, and those factors are probably much bigger than the risk of being on a proton pump inhibitor. But nevertheless, if you've got smoking and then you're on a proton pump inhibitor, that may increase your risk further. So again, like many of the conditions we talk about, it's a multifactorial thing. And obviously, if you're a smoker and you're inactive, that may be an indication for an osteoporosis scan anyway. There have been other mentions of a thing called acute interstitial nephritis, and that occurs very rarely in people on a proton pump inhibitor, and that's that. Really, it either happens or it doesn't, and if it does happen, it'll happen again if you take a second proton pump inhibitor. In terms of stopping proton pump inhibitors, generally, if people have been on them for less than 3 months, one can just stop them, and there's no rebound hyperacidity. But if people have been on them long term, there is a suggestion, although there's no formal well-recognised tapering regime, that there may be a rebound hyperacidity. And in that case, I think it's reasonable to reduce them over 1 to 3 months, perhaps halving the dose every week till you're on a low dose and then stopping it altogether. I hope that's been of some help. Thanks for listening.